that they should ask the patient, have you seen a dental provider in the last year? If the answer is no, do it. If the answer is yes, then they suggested that the physician not go in and probe the patient, but simply ask these 3 questions. Do you have bleeding gums, unsteady teeth, or gum recession? And if so, they should be referred to the dentist. So I think we're getting a little better about at least reaching out, about all of us understanding the importance of inflammation. The American Academy of Periodontology is having a big conference on inflammation later this year, and the Scottsdale Project and all of these, it's all growing toward us trying to decide how can we work better for the betterment of the patients. So back to my initial question. Should the movement from an infection model to an inflammation model of disease change the way we treat our patients? And again, it really should be the way I treat my patients, because I can't speak for you. I told you at the beginning of this that my answer was no, that I wasn't convinced that there was any reason for me to change. I can tell you, after re-looking at the evidence, talking to experts around the world, that I think, yeah, it at least is making me think about treating a segment of my patients a little different than I have in the past. When I have patients who have aggressive periodontitis, or I have patients who have periodontitis in the presence of other chronic inflammatory diseases, I'm thinking, at least in my practice, that I should have a greater emphasis on inflammation and patient education. A lot of pluses to this. You know, certainly this whole periosystemic thing is a great motivator for the patients to accept treatment. It seems to maybe be having some positive influence on third parties. And, you know, this whole thing may also be a call to action for us to reclaim the treatment of periodontitis and say that just, you know, ineffective treatment of periodontitis is just no longer going to be, you know, something that we're going to accept. I'm thinking that I need to expand my medical history to include more systems review, because currently there's no chairside diagnostics to identify these people. That perhaps by looking at a more intense systems review, that I can pick up some of these people, that I can then refer them to the physician, but also it will help me better understand how they're going to respond to my treatment. And if I can kind of push the inflammatory balance to a positive side, it may have a positive effect on my treatment. That I'm going to treat these folks more aggressively. If they're going to respond to plaque in a more exuberant fashion, then I can't take the wait and see approach. Now, note, I'm not saying we're going to over-treat these people, I'm saying we're going to treat them more aggressively. I'm going to consider short-term therapy with systemic antibiotics or host modulation to help control inflammation in these hyperinflammatory patients. I'm going to consider retaining fewer questionable teeth in this patient population for the reasons I've stated. I'm going to encourage risk factor modification. And finally, I'm going to continue to develop relationships with physicians and create referral networks. I've done this for a long time, primarily with ear, nose, and throat physicians, because I want to develop a relationship with them so that they can look at any pathology that I pick up on my scans when I'm doing it prior to sinus lifts, but also I want to do it so if I ever have a problem and I send the patient back, the ear, nose, and throat guy has at least heard of a periodontist doing a sinus lift. I can tell you that they appreciate private pay patients, me referring them to them, just like you appreciate those. I think we can continue to expand this network of developing relationships with our physicians for our benefit and, most importantly, for our patients. So to conclude, I, like the other 2 speakers, look forward to having the opportunity to give this kind of lecture 5 or 10 years from now, when we have more solid evidence to really pin our conclusions on. But as clinicians, we deal with areas of uncertainty every day, and we make our decisions on less than perfect evidence. And as the advocate for our patients' health, at least with this segment of the population, I'm going to err on more aggressive treatment, because undertreatment in this group of patients may result in more than just a loss of a few teeth. It's been our pleasure to spend this morning with you, and look forward to any questions that the group may have later. Thank you very much.
Thank you very much, Dr. McGuire. We'd like to be able to have a few minutes to take a few questions from the audience. What I'd like to do is ask one that's kind of a nuts and bolts question to all three of the speakers, and that is, because this has happened in my own practice and in others that I've heard of, and that is, you have a physician colleague that perhaps you've referred a patient to for medical evaluation, or maybe it's just a friend or a colleague, and they ask, Brian, what am I supposed to be doing? What am I supposed to be doing in my practice to help assess the patient's periodontal condition? So I guess since we have a cardiologist, we'll stick the question with him first. Has that come up in your own practice?
No, it hasn't come up in my practice, because I think actually on the personal radar, I think it's not really out there as much in the lay population, at least in our communities. So I haven't really had, I don't think I can think of a single patient that's really asked me about the connection.
Okay, well, because they often hear about it from us, how about from our two periodontists? What do you do when your physician colleague says, okay, there's evidence, what am I supposed to do to even find out if my patient has a periodontal problem, other than just refer it to you?
You know, I don't think we have the answer yet. I thought the opportunity to speak to the cardiologist in Barcelona and have a 2-hour symposium on the relationship of periodontal disease to cardiovascular disease, I thought that was a great move forward for our specialty. That 2-hour symposium focused on what is the evidence that there's a relationship between them. That wasn't what the audience wanted, and the audience complained considerably. That's not why they had come to the symposium. What they wanted to know was, what am I supposed to do in my practice? And in fact, they have asked that if we come back to their next Congress, that we focus on that. I am reminded from Mike just now that I think the Scottsdale project in April, Brian, which you were part of, is a first step in helping physicians have some clues as to what are they supposed to do.
Let's go ahead and take a question, please.
This question is Dr. Williams. Thank you for your overview. This was beautiful. However, this is my question. You have not discussed, except for 1 minute, the fact that there are numerous studies that fail to show association between some systemic condition and periodontitis. You mentioned that when it comes to CVD, there are like 16 to 18 studies, of which 10, a little bit over 10, were positive. But that means that 35 to 40% of those studies fail to show association. When it comes to preterm low weight births, none of the studies from Europe, I emphasize Europe, the Davenport study coming from West London, another study coming from Copenhagen a year or two ago, all of them fail to show association. Shouldn't we look into this study in order to make sure that we do not do the mistake that our predecessor did 100 years ago?
Well, I think absolutely. I think that any study that, you know, if you have 6 studies that show a positive association, and then now along comes one that doesn't show it, it doesn't do anything but make us go back and look further to see if we're correct. And so I look upon negative studies as just making sure that we are not emphasizing or overselling. If there had been more time today, perhaps I would have focused on some of the negative studies. But the negative studies simply are telling us to go back and make sure that we're getting it right. Usually we can find that they are underpowered, or that a study has thrown out a university center for some problem. There's plenty of work still to be done.
I'd like to add also, the reason why I focused on the studies I did, many of the studies were actually self-reported periodontitis, very, very different definitions. So I think when you look at the well-done, prospectively designed trials that have asked a question, even if they're just cohort trials, at least if it's well done, consistent with the same definition, I think that the the data as a whole is very, very consistent and actually very much in the same direction. I didn't see any negative trials of the well-done prospective trials.
Next questioner, please.
Thank you for a great presentation. I had a question for Dr. Williams. A common problem in epidemiology is classification error, misclassification. It seems that for the most part in many of our studies we've emphasized nosological or diagnostic schemes that emphasize evidence of past disease, namely attachment loss, and have overlooked perhaps more biologically meaningful methods of classifying disease, such as inflammation, although this was alluded to during the presentations. And I just wondered, ourselves and others have published some studies on biomarkers in salivary origin and GCF and similar types of things. And just wondered, Dr. Williams, what your thoughts were on this and how far we are from having some biologically meaningful diagnostic classification scheme we can use in these studies.
Well, I certainly think you are on the right track and you are describing the future. I am impressed and excited about how easy it is for us to measure a protein or a biomarker or an antibody in crevicular fluid or markers in saliva. I think the technology for quick, easy, inexpensive measurement is there. What we have not yet done is translated those findings into what it means clinically. We need to get there. And, you know, the Dongming Lin paper that I used as an example to say that we need to move away from probing depth into what is the infectious burden, what is the inflammatory response. I think people are beginning to take us that way, but we have to link it to clinical meaningfulness, but we'll get there.
Thank you.
This is an open question. You showed very nicely that the stability of the atherosclerotic plaque, rather than the size or the age of the plaque, is the crucial characteristic. And numerous studies have shown, including the recent one in the New England Journal of Medicine, that periodontal intervention actually in the acute setting raises the circulating level of inflammatory mediators. I was wondering what your thoughts are on the possibility that intervention actually could precipitate a thrombotic event in a patient who has all the risk factors and is sitting there with an unstable plaque.
Right. Well, I think first of all, if you look at the magnitude and the duration, it was extremely short. So we don't know exactly when it came down to baseline because it was only measured, let's say, in Cincinnati at day 1 and day 7. But if you saw for basically all the biomarkers, and including endothelial function, was already improved by day 7. So that's the longest that you could have seen the abnormality. But I think overall, when you look at the complexity of cardiovascular disease, oral inflammation is going to be probably one modest piece of the puzzle. You've got the diabetes, the blood pressure, the lipids, the weight, the genetics. So I think when you look at a small component like that, to see probably a statistically significant worsening of short-term outcomes is probably highly unlikely. And my guesstimate, if you look at other models, that if you would have really looked serially, that the response would have probably been even more short-lived, like several days. So since you do that all the time, in routine work, now that we see it done prospectively, it's not likely to enhance outcomes, I don't think.
We have time for just a couple more questions, please.
This is kind of a philosophical question for Dr. McGuire as a clinician. You talked about it being all connected, and I think intuitively we all know it's connected. And it seems to me that much of the disease we're dealing with is self-induced through environmental toxins, food, water, everything that we take into our bodies. And with that in mind, does it make sense for us to be learning more about blood chemistries and nutrition or working with nutritionists?
I think it makes a lot of sense to look at whole body health because it seems to well, there's no doubt that it's going to influence the wound healing on your patients and perhaps disease susceptibility and that whole issue. But I think the broader question is, how do you really fit that into clinical practice? I mean, that's something that we've struggled with for a long time, and it unfortunately gets down to, how can you make a living doing that kind of thing? How do you get compensated for those kind of things? That's kind of the clinical reality. And also the difficulty and patients don't want to be preached at. But I think that one thing we have going for us right now is that the patients have bought into this. Maybe the evidence isn't out there for the medical and the dental colleagues to be able to say for certain that there are definite connections. But I think we have an opportunity to leverage the fact that the patients now are beginning to understand that systemic health and oral health is intertwined, and it's an opportunity for us to try to reach out and influence those things like you're talking about. From a practical viewpoint in practice, it's not easily done.
Please.
I think I'm going to cut to the chase, and I'm very pleased that the Academy is looking at this issue very carefully. But we are going to be running into a problem with medical practice acts and practicing medicine without a license, which has come up with some other products that have shown up. And the issue that was brought up about taking blood glucose, this gets into the CLIA issues. And in California, we've been advised that it is better that a patient bring in their own blood testing kit and that we not do glucose testing. So the next question is, why are there no Perio-MD programs coming up? Why aren't we following our oral surgeon friends into a more broad, medically based Perio program?
It's a great question. Those of us who have been around for a while we've talked about this forever. The need to expand the training of the periodontist. We're doing it to some degree with the certificate MPH, the certificate MBA, the certificate MS types of programs. It's certainly something that we keep talking about. Maybe after your question, we should ask our education committee and both our pre-doctoral and postdoctoral education groups to bring that up for discussion.
Thank you. And what about the issues about CLIA in regard to Mike McGuire's comments about blood testing and the other things that technically we may be restricted in doing?
I really brought that up more as just something for you to think about. And as an example, I wasn't facetious about taking blood pressure. People laughed at dentists for doing those kind of things. And if you want to get down to specifics, it's going to be a state-by-state issue depending on Practice Act. And so you need to look at your state, and if you think this is something important, then you need to lobby for changes. But I was just throwing something out there that we are going to change in the future, and who knows, maybe that may be one of them. I'm not suggesting that we go out and start doing all sorts of blood chemistries and that kind of thing. But
the question is, why not, and will the Academy support us if we do?
I don't know why the Academy won't support anything that's in the interest of our patients.
I think if I can address that too, CLIA doesn't prevent you from doing anything in your office. CLIA requires you to do certain things if you elect to do them in your office. And one of those, glucometer testing, is not prohibited by CLIA. In fact, it's a CLIA waived procedure. You just have to do the appropriate things. And anybody interested in doing that can go to cms.hhs.gov, click on the CLIA button, and you can find Form 116. That's a CLIA waiver form. So that doesn't prevent you from doing it in your office. You just have to know the proper way to do it. Next question, please.
I am absolutely overwhelmed with excitement about this session. I'm a general dentist, member of the AAP since 1984, and have been attending regularly the meetings and so forth and following the literature. And in fact, I have a 16-hour accredited program that I teach in all of this. And in fact, in my practice, for the past 3 years, we have been doing regularly blood testing on our patients. I have numerous statistics. I've got tons of information that I teach and that I'm working to publish, and I would welcome anybody who is interested in working with me. We've been doing CRP testing, we've been doing A1C, we meaning me, myself and I, in my sort of high-level general cosmetic practice, probably 50% perio, 50% cosmetic and reconstructive. And it has, as you can imagine, required extraordinarily thousands of hours of personal time to put together, but I do have a program where I teach all of this. I teach nutritional support, which I'm so glad that I followed these two gentlemen. The one who spoke about nutrition, I have developed over the years a very intensive nutritional program that I use with my patients. It is extraordinarily successful. I am in the process of editing my final DVDs to present this to doctors, to teach us all how to do this better, more effectively in our practices, and how to communicate the excitement that this can add to the practice of dentistry, the comprehensive care of our patients from the top of their heads to the bottoms of their feet. And it is incredible how we transform our patients' health through the program that we do. We do the blood testing, we do DNA.